when we're talking to patients that have relapsed, and so where first-line treatment is not as effective as we would like, this is a highly stressful time for them. I'm Lorna Uoruik, and I'm the CEO of the Lymphoma Coalition. I have been working in hematology since 2003, spending a lot of my time working with patients with lymphomas, including diffuse large B-cell.
I'm Lori Sen. I'm here in Vancouver, Canada. I'm a hematologist and oncologist, and I treat patients with lymphoma as well as run clinical trials and translational research. And I have been doing that for longer than I can remember, probably at least 15 years now.
When a patient is first diagnosed, oftentimes immediately their reaction is shock. How did this happen to me? Why did I get that? Is there something that I did or my family did? And then it switches into, am I going to live? And Lori, I know you have some insight from what you communicate to patients when they're first diagnosed.
When patients come to me, they've usually been told their diagnosis by one of their other healthcare providers, but I don't think they fully understand it. So there's a large element of anxiety, and they think that this is a death sentence and incurable. And I think one of the biggest reliefs that patients have is when we talk about the current treatment options that we have for aggressive B-cell lymphoma, that many times we can actually cure the lymphoma despite it being advanced stage. And I think that lets them calm down somewhat and focus on, okay, what's next? What can I do to be one of those success stories? And what is treatment going to involve?
A patient is diagnosed with diffuse large B-cell. Often they will hear from their doctors that their prognosis is pretty good. And that's because really with current therapies, about 60% of patients have a durable response to them. And that is encouraging, but still problematic because we're not obviously at 100% of a cure rate for our patients.
When treatment ends at about the 6-month mark, we know that patients enter a period of uncertainty where, despite having an initial good response, we still know that they're at risk for their lymphoma coming back and relapsing. The good thing is that obviously the farther we get away from treatment, the lower the likelihood of their lymphoma relapsing and the higher the likelihood that they've actually had successful treatment. At what time frame do we get optimistic that we won't see the lymphoma come back? Well, we have good data to show us that the majority of patients that have their lymphomas recur will do so within the first 2 years. So that's a bit of a milestone.
When we're talking to patients that have relapsed, and so where first-line treatment is not as effective as we would like, this is a highly stressful time for them. For most of our patients, we are really actually hoping that first-line therapy works because it is usually the best time for treatment to be effective. Once a patient starts relapsing, again, there are limited treatment options available for them, and their disease, because it's progressing rapidly, becomes harder to treat. And I don't know what you have to add to that, Lori, but if you see something similar where patients are really becoming more involved in actually trying to understand what options would be available for them since that first one didn't work, they maybe have a little bit less faith in the medicine that's available now.
Yeah, I think there's a lot of optimism with first-line treatment where, patients and doctors are hopeful that we're going to be successful and cure the lymphoma, and that's always the goal. But I agree, the stakes really go up once patients have that relapse or progression. We know that the second line and beyond therapies don't have the same capability of eradicating the lymphoma, and so it does become a much more threatening situation. The goal of therapy is usually to try and maximize the benefit from frontline treatment. So we know that our best chance of curing patients with aggressive B-cell lymphoma has been with frontline therapy. But despite that, about 40% of patients will inevitably progress or experience relapse disease. That's a very challenging situation because our options in the second line setting and beyond have been very limited and usually require much more intensive treatment. So second line therapy and beyond is really challenging for patients. There's the uncertainty of the benefit and of course the intensity of the treatment that comes along with it as well. How would you say that they deal with second line therapy, Lorna?
I would agree that it is really challenging on many levels, especially when we're looking at patients who are getting progressively sicker. When we're looking at some of those other therapies where you're right, the limited patient populations can actually tolerate those treatments. But even from a patient perspective, sometimes those more advanced therapies, whether that be a stem cell transplant or CAR T, happen in a different center with a different doctor, a different medical team. And so the patient is not only adapting to a different treatment, but different healthcare professionals that they're working with, and they may not have a relationship with at that point in time. So there can be additional disruptions over and above trying to actually medically get them under control. And of course, as you pointed out, some of the new therapies are very expensive. We know that treatment for lymphomas changed dramatically over the last 20 years. So Lori, can you talk about that a little bit and how that has changed the course for diffuse large B-cell?
With our current standard of care, R-CHOP, we know that we've got a very effective treatment for the majority of patients, but unfortunately, many patients will prove to show resistant disease or be refractory to R-CHOP, and that continues to be a very big challenge. But there is a very big need to improve upon upfront treatment. I think part of the problem with being able to do that is that, R-CHOP has been our standard of care for 20 years plus. It is a fairly intensive treatment. It relies on a package of chemotherapy. So, the focus in many clinical trials has been to try and build on that backbone of R-CHOP. But that can be really difficult when you're starting off with a treatment that's quite intensive. If you're going to add to that treatment, you're probably going to be adding on toxicity, and you might find that the whole new package is not tolerable. So the goal is to try and understand, why in certain patients, the disease is defying R-CHOP, and how can we bring in treatments that overcome that resistance, but we need to bring in treatments that are tolerable for patients while still being able at this point in time to deliver the best treatment that we have.